So thank you very much to this panel. Dave, terrific job. I want to add to the thank yous a little bit. Can you hear me back there? I want to thank, first of all, Dave Kindig, my co-chair, for getting us this far and doing a fine job of doing that. I want to particularly thank George Flores for chairing the Planning Committee. Also, members of the Planning Committee, Debbie Chang, David Kindig again, Jeff Levy, Judy Monroe, David Chusky, Kavita Patel, and Andrew Rain. And particularly, I thought they've done a nice job of putting together today's workshop. I want to add a thank you to IOM staff as well, Alina and Lila Hernandez and Colin Fink and Drew and Rose Martinez. So terrific. I want to thank them as well as everybody for their participation over the course of the day. I have one other announcement before I get to summary, and that is that the Roundtable is meeting tonight in a dinner meeting. And so if you'll make sure you connect with the staff before the end of today's session, you'll make sure that you're going to the right place for that meeting. So we're now at the point where we need to be looking at what we've heard over the course of the day and reflecting a bit. I have a couple of observations I might make to get the ball rolling, but since this is the first time we've really done this as a roundtable, my expectation is that each of the roundtable members is going to come to the microphone. I've got a list. And share briefly 3 observations or less, observations or reflections upon the day. So it doesn't fall to me to do this job. I think what we want to do is make sure that this discussion over the course of the day is complete by some reflective input in terms of what we've heard over the course of the day. So since this setting is such that we'll want that to be into microphones, and I want to make sure that those who are still with us on the WebEx can hear that, you're going to need to line up at either one of them or the other of the microphones. So you can do that voluntarily, members of the roundtable, or I can call on you, either way. I'd prefer the voluntary model myself. So let me just make a few observations. This is by no way comprehensive or complete. First of all, appreciate George Flores' opening discussion to set up the day. I particularly thought it was clear and well done. And I really appreciated you highlighting the dilemma between the population, potential for population health impact versus individual impact, and George making the observation that he was worried that many of the healthcare providers don't yet appreciate that fact. He also provided us with a very nice beginning list of the many opportunities that are available under the ACA for us to address. In panel 1, we had 4 very interesting examples to learn from of different efforts that are going on. I was struck personally by how there's no apparent template for this work yet. And I made that observation. We have 4 very unique approaches to trying to get at the same problem. And maybe that's okay for where we are now. But it also lays out for us a challenge in terms of figuring out where some of those key common points might be if we're going to take that and move it from individual sorts of initiatives that are designed from goal 1 and then put into some kind of framework that makes sense. Hillary, would you mind going to the microphone with your list? Hillary, I ran into, from Robert Wood Johnson, I ran into at the first break, and she was busily rattling off her list of things that might be conclusions. So I told her, so lest you feel that I'm picking on her, I told her that I was going to call on her and ask her to read her observations. And I want particularly for you to note that she made these observations or wrote down this list before the outstanding presentation we had at noon from Steve Chartel. So Hillary, would you mind very quickly saying?
I will, but I'm going to claim the opportunity to give just a statement of context of where this comes from. And so I would say, as he said, I'm Hillary Heischman, Robert Wood Johnson Foundation, here in place of a couple of my colleagues. So I work on a lot of things, but one of the programs I work on is Aligning Forces for Quality. And in Aligning Forces for Quality, it was designed to address sort of key levers in the healthcare system. Payment reform, using payment reform, using quality improvement, using consumer and patient engagement, using, the fourth piece I'm missing here. Anyway, the point is using levers in a system, thinking of the system. And, you know, Don Berwick has his quote about systems that I can't quote exactly, but it's something about each system is perfectly designed to do what it does. And so I'm often thinking about how can you change the levers in the system, and as with Aligning Forces for Quality. So in this realm, when I'm thinking about what are the levers for a system that produces health at the community level, you know, I was putting together this list, and many things we talked about today sort of fit within this framework or rubric. So the things on my list are, and these aren't original, these came from you all today and have come from other places. Having a collaboration, so, you know, the multiple stakeholders across the community working together. Addressing the flow of money, sort of a generic way of talking about addressing incentives, you know, how aligning physicians and hospital payment, all those various pieces, but sort of the broad category of addressing the flow of money. Addressing the flow of information, so that has to do with assessment, community health assessment, it has to do with monitoring performance in the healthcare system, having a way of linking that information together, health information technology, HIEs, and metrics for that, and feedback loops for that. So we have collaboration, flow of money, flow of information, having an integrator. Debbie Chang mentioned that a couple times, and there's various words for that, and various groups have noted the importance of having an integrator. And with that, though, that also means leadership, having leadership. There is this having an agreed upon vision and culture and goals. So it's like it's a North Star for the whole effort. So that would be another key piece to move the system for health in the right direction. So that's 5 things. A 6th one would be community member, or in the case of healthcare, we think of patient engagement, but community member engagement and involvement. Veva spoke to the importance of that so eloquently today. A 7th piece would be training and appropriate role definitions, and that has to do with team-based care, that has to do with the role of community health workers, that has to do with the gentleman who spoke up from GW over there. Yes, behind me, yes. There, exactly, your question was exactly what I was thinking, the importance of training so people know their role in the system, and the system tells them what their role is through certification and licensure and defining the roles. QI, meaning you have feedback, meaning you have continuous learning and improvement. People have talked about that today. And then having some sort of roadmap for the whole thing, which is the idea of community health improvement plans that collaboration has worked on to you know, has agreed upon together. So it's like we all know what we're working on and what we're working towards, and we've agreed on it, and we have the metrics. So I think that's 9 pieces. With most of what we've talked about today would fit in a framework under those 9 pieces. And the last statement I'll say, and then I'll finally sit down. Thank you, George. The last thing I wanted to say is that if you think of this as the pieces that get the system moving in the right direction, all of the other things that you're talking about as individual programs that are so great and so important, if you implement them without getting the system moving in the right direction, their chance of sustainability is so much less. But if you have the levers going right, if you have the system moving in the right direction, that when you implement these great programs with community health workers or with whatever, all these great programs, the system, they have a chance of sustaining because the money is flowing right, the information and transparency of information is there, and so on and so on. So just importance, I want to speak to the importance of thinking of getting the system moving in the right direction.
Thank you, Hillary, for helping me. Appreciate that very much. Also heard over the course of the day a lot about culture, culture of care delivery, culture of public health, and the need for culture that's population health. In other words, something that is beyond both those separate cultures. Heard a little bit about, and I picked it up mostly in the breaks and in comments that people made, the tension between public health and healthcare delivery. I don't know we've made that explicit in the presentations, but there is tension out there. I noticed in George Flores' slides he had a list of opportunities for, that came out of the ACA mentioning the National Prevention Strategy, but he left off the National Quality Strategy of the AAA. And yet the panel that followed him, mostly healthcare delivery, focused mostly on the AAA. And so very interesting in how those federal strategies are parallel, but not yet integrated. And I think there's an opportunity there, actually. Collective impact. We heard collective impact several times. Buzzword. 5 conditions for collective impact. Common agenda, shared measurement, mutually reinforcing activities, continuous communication, and a backbone of support, in other words, an infrastructure. It's very interesting to think about that concept, which is a response to what the authors talk about as a complex adaptive system, which is surely what we have in healthcare and health today in this country. Very complex system. So there may be some interesting things to learn there. Obviously, funding is a big issue. I clearly heard fee-for-service is dead. And I heard that, boy, the change in categorical funding for public health is needed. So there's a parallel on both of these cultural paths, dissatisfaction with currently how the money is flowing, Hillary, in terms of your one issue on both sides of this cultural fence that we have in our health system. We heard the bold proposal from Shortell, create a risk-adjusted population-wide health budget to be overseen by a community-wide entity tied to multi-year targets. And I think that gives us something to think through. Over the course of the afternoon, a number of interesting comments. Again, I thought the news from the Innovation Center that the second round of grants is being worked on with a population health focus, among other focuses, is important. I thought the discussion, particularly the discussion of Jim Hester of the challenges, that section of his discussion, which I won't reprise now, is just absolutely wonderful and something that gives us something good to think about. And then John Auerbach, Massachusetts, talking about funding, and I think that was particularly helpful. And I know I have not mentioned all of the things that have come up, but now I would really like members of the Roundtable to go to these microphones. We don't have a long time. You need to be brief and succinct, and we need to do it quickly if we're going to get these observations into our workshop.